So, hello friends. So, I'll be talking on this topic palliative care in intensive care, needs in ICU and triggers. So, this talk I gave in Indian Association of Palliative Care International Conference that happened in Bangalore on 11th of February 2023. So, the topics that I would be covering. So, I'm sure many intensivists hearing to this talk would be aware of end of life care, which also is a part of the palliative care. So if you look at palliative care as one big umbrella sort of a science, so end of life constitutes one aspect of this dimension. So the topics that I would cover is a bit on a background and why the need for palliative care becomes relevant for ICU and what are the components of palliative care in ICU. And we look at who are the people who should deliver this palliative care in ICU, and when is the right time for palliative care to be considered is something that we look into. And we look into how the palliative care has to be delivered to a patient in ICU and what are the different nuances that may be involved. And we'll talk about conclusions. So these are the sort of broad categories that I would discuss. So when you look at palliative care, so the palliative care is a science that it involves the patient and the patient family. So it is not confined only to the patient. And the intent of palliative care is to optimize the quality of life where there is no definitive cure or curative ability for the patient. So there is no definitive cure, but the care is being continued to optimize the quality of life. And this optimization happens with anticipation and taking some preventative measures and some therapeutic modalities to address the symptomology of a patient. So the whole dimension of palliative care focuses on symptom alleviation or symptom relief or any specific reversible aspects within that non-curable condition that patient may have that will be addressed, which we call it as a symptom resolution. And end of life, as I said, is one of the components in the whole dimension or the scheme of this palliative care. And the third important aspect of palliative care is ongoing and good and careful communication with the family members. So this communication becomes a very important domain. And communication is with an intent to set the goals of the care. So that is the aspect where the communication plays an important role to create goals of care that we provide for the patient, encompassing the patient's preferences and the values that would be governing the care. So these are the components of palliative care. So one is the symptom relief, end of life becomes one aspect, and ongoing communication, setting the goals for the patients, keeping his values and preferences in mind is what constitutes the domain of palliative care. So, but there are debates there are certain debates in palliative care, which there is which these are the areas which are a bit nebulous and they may not be well defined, which is the patient selection. What type of patients that we choose, where we determine that palliative care is needed, still there can be gray areas around this. And what are the models that are available that one could apply the science of palliative care? So application modules, we have a little bit of a debate. And what are the identified triggers that determines as to the palliative care needs of the patient? So the triggers is something where these are some of the contentious areas which are debatable. So when we look at the background, so the ICU death rates worldwide is put as 20 to 35% is the approximate death rates that happen in ICU. And this is an interesting thing that has come out in these articles from US, where increasingly, slowly and steadily, the last 1 month of any patient's life or any person's life is being increasingly spent in ICU. So this percentage is increasing. So the last month of anybody's life, it is increased up to 30% are spending in ICU, which means before the death in a person's life, 30% of them are spending time in ICU, and it is becoming important that palliative care needs are addressed for this group of patients. And the typical patients where palliative care in ICU, one would be concerned, we'll talk about different conditions. So any patients where they have multi-organ dysfunction and and they are not really responding to whatever organ support or treatment modalities that we may have instituted, and patient is on life support and all the other supports which are not proportionate to the prognosis. So you are giving a lot of supports, but not necessarily that patient would possibly get better from all these supports and have a good prognosis. So this is where intensivists should facilitate the process of palliative care science and take them through the process of acceptable death of the patient. So that is where the conversation or the science of palliative care needs to be applied, where there is definitive indicators suggesting that recovery to wellness is not going to happen, or recovery from the organ support measures will not be happening, and acceptable death remains possibly a better the pathway that one should be looking at. And continuing these organ support measures where one is sure that prognosis is not going to be good will only burden the patient financially and with regards to various other dimensions. So that should not be the intent. So the intent should be to lessen the burden and facilitate the peaceful death is what one should be looking at. So this is something important for intensivists, that there are definitive conditions where we know that whatever treatment we are giving, uh, it is going to be futile and inappropriate. So way back, many centuries back, Aristotle had mentioned this. So not to treat a patient who are overmastered by their disease. So this was mentioned way back by the Greek Aristotle, that one should not be treating where the disease is too overwhelming and one knows for sure that certain death is inevitable. So there are various definitions of futility. So there's physiological futility, quantitative futility, qualitative futility, and lethal condition futility. And there is imminent demise futility. I'm sure any intensivist who is hearing to this would know what is imminent demise. So patient who's on multi-organ failure or a lot of support, with increasing inotropes, we know that patient is going to die. So lethal condition futility is where you have an underlying possibly advanced cancer with metastasis. You know, there is no reversibility to the condition. So, and patient would have death despite whatever measures one is putting in place. Qualitative futility is where patient has been bedbound, his quality of life has been very poor, and he's fully dependent. So you know that putting them on life support measures or any other measures is only going to prolong his agony and distress, and it's not going to change the outcome. And quantitative futility is the tremendous amount of resources that may have to be put in and not necessarily that may change the outcome. Physiological futility is where your underlying physiology is so much deconditioned or the variables are suggestive that the outcome is going to be bad. So these are some of the definitions, and I'm sure there will be an overlap between these definitions. So some of the common conditions which one could relate to in ICU where medical futility is sort of established is any organ failure. So any elderly individual who is frail, someone like this, having an end stage disease of any nature like CKD, chronic liver disease, or end stage COPD, who's on home oxygen, or interstitial lung disease who are on home oxygen, or advanced heart failure and a deconditioned patient who is wheelchair bound with limited mobility, or severe refractory illness with multi-organ dysfunction who are not responding to all organ support or other therapeutic modalities, and hypoxic ischemic encephalopathy. We know for sure. So this is a physiological futility where you know for sure that despite optimizing any other parameters, the brain function would not improve. So and these are some of the futile conditions, or chronic progressive degenerative neurological conditions like Parkinson's, dementia, or motor neuron disease, so on and so forth, and metastatic cancer. So these are some of the broader dimensions which I put where one could relate to the futility despite whatever support measures that one would institute. And this is something which most intensivists would relate to. And any other condition where you know for sure that survival is not going to happen. So, and we know one thing for sure that someone who is on a ventilator or life support measures, for them it is not possible that the patient is in a position to make decision with regards to what he wishes. And this is where the advance directive or a leaving will, if it is made, or if patient has already expressed some ways, that could be used as a guide to influence or to help you make a decision. And for this, a good communication with the family, keeping these important parameters of autonomy, if there has been an expressed wish to the family, capacity determination, and surrogacy. So these are the three components which need to be touched about when we are discussing with the family. And by encompassing all this, one could possibly be guided as to the what is the right decision that needs to be made to the patient. And when we talk about instituting the palliative care, there should be a reasonably good knowledge about the use of sedation and analgesia to alleviate the distress and pain. And this also needs to be addressed to the patient and to the families as to how you are taking them through the process of palliative care or end of life, because they need to understand what are the measures that you are going to institute to alleviate the distress and pain when you are instituting the palliative, the science of palliative care or end of life care. So, and some of the key aspects or the goals of palliative care is to remove the anxiety. So, when I talk about all this, the anxiety can be for the patient and can be for the family and can be for even the doctors if they're not well versed or if they do not have sound understanding of the science of palliative care. So, whatever uh, dimensions we are talking with regards to the goals, it applies to patient, families, and to the healthcare professional. It may even apply to the nurse. Nurse may be very anxious to know that something is being stopped for the patient. And another important aspect is to alleviate the symptomology or specific clinical problems that patient may be facing. So alleviating the symptoms which may be troubling the patient is also an important aspect of palliative care. And the patient, if he's dealing with, say, terminally ill cancer or neurologically he's fine on a ventilator, so a lot of sleep disturbance may be there, insomnia or shortness. So ILD patient who is on a home oxygen, he may have a lot of shortness of breath. So measures to alleviate these symptoms become part of the palliative care. And as I said, some of these symptoms like insomnia and some of the functional symptoms, anxiety, depression, all this can remain, can is applicable for the patient and to the family also. Family members also will be anxious. Family members also can have functional symptoms. Family members can also have insomnia. So the palliative care is a science which addresses not only the patient's needs, but also the family needs. And most importantly, it applies to the doctors also. And patients would have this post-ICU syndrome, which they can have cognitive, psychiatric, and physical symptoms. And that is something that they need to keep in mind as well. And that needs to be addressed. And as I said, the last but not the least is the doctors or the healthcare personnel also will have a burnout syndrome when they're dealing with these end of life situations or when they're dealing with the grieving families. So, and that the needs of the doctors or the healthcare professionals also will be addressed by the palliative care side. So, palliative care is for the patient, families, and for the healthcare professionals. So, that is what I want people to just understand. So, intensive care and palliative care or although they appear different, so they are at a different extremes of the healthcare. So where ICU, it is called as technical medicine and palliative care is more of talking medicine. So there's a lot of emphasis on communication with the patient, communication with the family, and communication with the healthcare professional. And they both are interdependent. So some of the components are they overlap between ICU, and I'm sure every listener of intensive care, you would be doing this. You would be talking to the family. You would be showing your empathy, compassion to the family and to the patient. So there is a overlap, and it is a virtuous interdependence between the intensive care and palliative care. And fundamentally, some of the features are very similar to ICU and to the palliative care. So why we need palliative care? So in intensive care, it is shown that 25 to 75% of the patients will have unrelieving and distressing symptoms. So which not necessarily in our zeal to do other things, we may not be paying attention to that. And one third of the patients can have delirium in ICU. And this was a study which is very interesting, which again reemphasizes as to why the science of palliative care extends to the family. So here, this was a study where they showed the relatives, 57% of the ICU patient relatives have traumatic stress, and 70 to 80% of the patients relatives will have anxiety and depression whilst their dear ones is in ICU. So this is something which is important for intensivists to recognize, and this is where the science of palliative care becomes important. So when a situation of this nature is there, so palliative care science should be adopted as soon as possible with a focused intervention, anticipating the suffering and trying to take efforts to minimize this unnecessary suffering. So that is the whole purpose of palliative care. And the intent of palliative care is to avoid aggressive therapeutic modalities when you know that there is no definitive cure for the condition, and to prepare the patient for the process of death as to how the process of death will happen, and adopting the science of end of life care and applying the science of end of life in patients where there is no curative intent, and applying end of life measures, which again I'll be repeating quite a bit, like alleviating the symptom onset. And end of life is also about taking them through the process of death with dignity and respect. And it is shown that 14 to 20% of the ICU patients meet triggers for palliative care, and one needs to be proactive in applying the science of this palliative care. And by proactive means starting the communication early on about the principles and taking into confidence the patient attenders and alleviating their anxiety, depression, so on and so forth. And this has shown to reduce the hospital length of stay. And it is shown that increased patient satisfaction in a patient who may be dying or who may be for a comfort care and who do not have a definitive curative intent, good quality communication has shown to be very, very important, and shared decision making and specific care addressing some of the clinical pain points is shown to improve the patient satisfaction. So then the question is, where do we provide this palliative care? So do we provide this palliative care in a separate area or in ICU? So there are three studies where they have shown that the palliative care can be provided in a separate palliative care sort of a area or a center. But ideally, the modern view is ICU. For ICU patients, it is desirable that palliative care is provided within ICU, because they will have certain symptomology that needs to be relieved. So they may need sedation, they may need analgesia, and so these things, and they may need some medications which possibly can be administered in ICU. But it is recommended that there is a palliative care specialist who is involved, who can oversee this care within ICU, is what has been broadly agreed as per consensus. And what are the components of palliative care? Again, I'll be repeating. So the components is to relieve the physical distress of the patient. There is psychological distress, and most importantly, which possibly we intensivists don't do, is spiritual distress. So someone who is for palliative care, one should address the spiritual or existential distress that they may be having, and which possibly in intensive care we may not be paying too much attention to this component, and even to the psychological. We may be addressing physical distress, but psychological and spiritual distress is something possibly as an intensivist we may not be very much sensitized to. And palliative care also involves the prognostication as to how much time the patient may be having, and good communication, and setting the clinical goals, keeping the patient's preferences and values in mind. And these are the important components. I know I'm repeating this, but the whole science of palliative care revolves around good communication and setting goals, clinical goals for the patient, keeping the patient's preferences and values. And these sentences or this narrative we will be repeating because this forms the fulcrum of the whole palliative care. And proactively identifying the patients who would benefit from this palliative care with shared decision making to make advanced care plan and to create a scenario how we take them through the process of end of life are the important aspects of palliative care. And when we are doing this advanced care plan, one needs to keep the legal and ethical aspects also. And one needs to take care of the patients during the whole dying process. So there is in end of life process, that is a separate science, which I will not be talking in this talk, where one has defined what a good death is. Good death is where the patient is comfortable, pain-free with the family around. And here you see there is a family who is praying and having some spiritual sort of a practice there. So all this defines good death. And good death also means that they should be in a comfortable environment with family present. And in palliative care also involves post-death taking care of the family's bereavement and addressing their grief. That also becomes an important aspect of palliative care. And the intent of giving sedation or analgesia is not only to relieve symptoms, to lower the level of consciousness. So that is something which possibly is little more important. So the whole science of sedation and analgesia is to lower the consciousness so that the awareness of suffering is eliminated. So the modality and intent is little bit different to the routine sort of a sedation practices that intensivists adopt. So now the question is, so who are the people who should get palliative care? So it is shown that it improves the quality of death, and the whole process of death happens in a seamless way with less suffering. And that is very important. So who offers palliative care? So there is something called integrative model and consultative model. Integrative model is where palliative care specialist or palliative care trained personnel is present within ICU and is part of the ICU team, and is involved in symptom alleviation, and they are involved in counseling, and they are involved in shared decision making, keeping the values of the patients, preference of the patients, and setting the clinical goals. Or there is a consultative model where palliative care specialist comes to ICU based on references that we give, and for an identified patient. So these are the two models that are defined. So the 2004 Association of Critical Care Medicine suggests that spiritual practices should be a part of ICU care plan, and the intensivist and the healthcare team should review the spiritual practices that are adopted, and a feedback has to be taken about the spiritual. So this is something possibly which is not well established, and maybe it's about time that we start dwelling about incorporating spiritual practices, because this becomes part of your intensive care and palliative care. So adopting this in our care plan is becoming increasingly important, and possibly we should put more effort in this science, which possibly we haven't yet. And palliative care also involves taking care of the patients where they may be on some life-sustaining therapy who is expected to survive. So the typical example we can cite is, you may have an ILD patient who is on home oxygen, who may be short of breath. He may have some time to live, so you would be giving oxygen, and there are certain other dimensions that you may be involving, and he may survive for a few months. So it is not like palliative care is only taking care of death. It is taking care of a patient who is meant to survive for some time. So it may be a cancer patient who may survive for a 1 year. So, but the care that is given during that period with regards to symptomology, uh, alleviation, and with regards to communication and keeping the patient's preferences, all this constitutes palliative care. So who should provide palliative care? The best model that is accepted is an intensivist who has some training or who has some understanding about palliative care with a palliative care specialist. So both together forms the perfect team to provide palliative care is what is recommended. And we have these two models, integrative models and consultative models, which we spoke about. So then the other question that arises is, when do you provide palliative care? So we look at life like this, that it is going smooth. Then, but at some stage in life, one may be troubled with a chronic disease where this gets halted. So fortunately, we have medicine which will make patient recover and continue with the life. But there are certain diseases which are non-reversible. So that's when patient starts deteriorating. So this is where your whole role of palliative care comes in role, where one needs to have a discussion that patient should be kept comfortable, and your whole focus of management changes from curative intent to taking care of the comfort aspect. So that is what. So when there is no definitive cure, the whole care shifts from cure to comfort care. And during this comfort care, there may be certain treatment modalities that you would be adopting, which is proportionate to the symptoms that may have, and you would not take inappropriate measures. And this is the stage where patients should be assessed early on in ICU for adopting the signs of palliative care. So the patients and the family should feel free to share their fears and concerns. And this is the time where there is a constant exchange of information that should happen between the palliative care team, patient, and the families in an integrative way to alleviate the distress and symptoms. So the first aspect of palliative care is that there should be no pain that should be caused to the patient or no distress to the patient at any time. So the second aspect of palliative care is to respect the patient's dignity, his likes, and to make right decisions. And the third aspect is to allow the patient to express his preferences, his values, and try to adopt it in the care plan that you may have envisaged. So the whole intent of palliative care is not to hasten the death, at the same time, not to slow down the whole inevitable end that is going to happen. So it is a fine line between not hastening and not delaying or allowing the patient to undergo a lot of distress and pain. So throughout end of life, the goal is neither to speed up nor to delay the end. So end of life is not about stopping care. It is about giving more comfort and making the pain, making the suffering less. So the care with which we treat the dying affirms that our humanity is living. So, and it is shown that by adopting the science of palliative care, so this was the study which came where they showed discontinuation of mechanical ventilation happened in 29%, discontinuation of inotropes happened in 16%, and discontinuation of artificial nutrition happened in 15.3, and discontinuation of dialysis happened in 6.4%, and discontinuation of fluids happens in 2.5%. And symptomology treatment to alleviate the distress was recommended when palliative care was adopted in 51%. But what is important is advanced care planning increased from 33 to 83.4% when the science of palliative care was included in ICU, which means there can be an advanced directive where disproportionate treatment modalities are not adapted when we know for sure that there is no curative intent. So this is what happened, which is important. And all this together by removing patient from a ventilator and not allowing him to suffer and discontinuing inotropes and all this improved quality of life and increased the establishment of advanced care planning and reduced the usage of unnecessary life sustaining therapies. So which are not of benefit to the patient, that was reduced. And all this together showed reduced in the length of hospital and ICU stay, because otherwise you would not incorporate palliative care, then some patient would be on a ventilator for a very long period of time, and the ultimate result would patient would die, but still you would have continued the ventilator, like, or the example would be hypoxic ischemic encephalopathy. We know for sure once a diagnosis of hypoxic ischemic encephalopathy is made, so we would know for sure that patient is not going to get better. But keeping him on ventilator unnecessarily would only prolong his agony and increase his hospital length of stay or hospital ICU length of stay, so on and so forth. So these are some of the situations which any intensivist would be dealing in day in and day out, where our intent should not be unnecessarily prolong the suffering and distress, where we clearly know that the outcome is going to be abysmal. So this is what is the science of palliative care. So to conclude, the ICU care that every intensivist are currently doing and palliative is not hugely different. So fundamentally, the components of care are very similar and there is no huge difference. So fundamental features remain the same, but what we need to understand it is non-sequential. When we say non-sequential, there is overlap of palliative care. It's not like after ICU care, we take them to a separate space where a separate palliative care is given. It's nothing. So they are overlapping and complementary to each other, and they are simultaneous. So it's not like palliative care is they go out of ICU and then we institute palliative care. Palliative care is an integral component of the ICU care, and they complement, they synergize, and they happen simultaneously within ICU. But there are certain barriers in palliative care. So when you say palliative care, one should not have unrealistic expectations, and one should not get into the mindset that we have incorporated palliative care means that we are hastening the death of the patient. And when we are looking for core evidence as an intensivist, it's difficult to evaluate, but you saw some articles which said that adoption of your advanced care directive significantly increased, quality of life improved, and reduced hospital length. But evidence to get a core evidence is difficult to evaluate because of the heterogeneity of the patient population. So integrative or consultative models is what is adopted for palliative care, and it is shown to reduce ICU and hospital length of stay. And it is suggested that daily pre-rounds with palliative care team and ICU team has shown to improve the adoption of palliative care science within ICU. So which means there should be some sort of a consultation that should happen in palliative care for certain group of patients in ICU is being suggested. And it is shown by having a pre-rounds with palliative care and ICU teams, increased adoption of palliative care happens from 5 to 59%. And that was shown from the study. And it is increasingly recognized that every intensivist should be competent in knowing the practical aspects of palliative care and ethical aspects of palliative care. And intensivists should be well sensitized on the withdrawal or end of life therapies or end of life science that is available. So one should know the concepts of this. And every intensivist, I'm sure, is familiar with the usage of the sedation and analgesia with an intent to lower the conscious level also, and non-pharmacological approaches, which includes communication, counseling, so on and so forth. And it is suggested that every intensivist or intensive care trainee should undergo training, constant training about palliative care science, end of life, and good communication skills and palliative care skills. So that's about, in essence, science of palliative care and its role in ICU. So thank you one and all. So end with this beautiful quote. You can't change what's going on around you until you start changing what's going on within you. So unless we understand within ourselves the science of palliative care, we may not be able to apply this science. So it's about time that intensivists get sensitized on this whole science of palliative care. I'm sure each one of you would have heard of end of life care. End of life care is a part of the palliative care, is embedded within. So the science, there's a lot of overlap between the science of intensive care and palliative care. So you can rehear to this lecture by visiting my website www.drpradeeprangappa.com. So thank you one and all.